A broken ankle heals. 6 weeks in a cast, the bone knits, the films look perfect. Then the cast comes off and the foot is wrong. It burns. It changes color through the day, dusky, then flushed. One sock comes off damp and the other does not. A bedsheet across the toes is intolerable. Everything the patient describes goes into the chart as unexplained. It is not unexplained. It comes from a chain of nerve ganglia against the front of the lumbar spine that no one has examined because it does not appear on a bone film. I am an interventional pain physician. Let me show you what is actually happening. And this is the lumbar sympathetic block, what it targets, what it can honestly tell you, and where the evidence is weaker than most clinics admit. This patient gets failed twice in opposite directions, and both failures are profitable. The first failure is the MRI reflex. Burning pain down one leg triggers a lumbar MRI. It shows a disc bulge, which about half of pain-free 40-year-olds also have, and the pain is labeled radiculopathy. Gabapentin, a home exercise sheet, next patient. Nobody puts a hand on the limb, measures its temperature, or notices that the pain ignores dermatomes, wraps the foot the way a sock does, and worsens in cold, none of which behaves like a compressed nerve root. The second failure is the opposite sin. Somebody recognizes complex regional pain syndrome and immediately sells a series, 6 blocks, 12 blocks. Booked before the first has told anybody anything. That is a subscription. The lumbar sympathetic block is a question, not a course of therapy. The lumbar sympathetic chain is not inside the spinal canal. It runs along the anterolateral surface of the lumbar vertebral bodies, L1 through L5, separated from psoas by a thin fascial plane. Blocks target L2 through L4. These fibers set the caliber of the leg's blood vessels and drive the foot's sweat glands. No motor supply, no touch sensation. That separation is the entire reason this procedure is diagnostically useful. The leading explanation for sympathetically maintained pain is that after injury, pain-carrying fibers become abnormally sensitive to the body's own norepinephrine. Sympathetic outflow that would ordinarily adjust blood flow instead drives the pain signal directly. That model comes largely from animal work. It does not apply to every patient, and it remains genuinely debated in humans. Any physician who presents adrenergic coupling as settled biology is overselling it. The differential has to be closed before anyone reaches for a needle. A hot, swollen, discolored calf is a deep vein thrombosis until proven otherwise. That is an ultrasound. A cold, pulseless foot with claudication is arterial disease. That is a vascular study. Symmetric, stocking distribution burning in both feet is more likely small fiber or metabolic neuropathy. Glucose and A1C belong in that workup because a metabolic driver will not be blocked away. When those are excluded, diagnosis rests on the Budapest criteria. Continuing pain, disproportionate to the injury that caused it, at least one reported symptom in 3 of those 4 categories, at least one sign I can observe myself in 2 of them on the day of examination, and no other diagnosis that explains the picture better. What I have described is type 1 eyes after a fracture, a crush, or immobilization with no identified nerve injury. That is the form the validation cohort was built from. Where a named nerve was cut or damaged, it is type 2, and electrodiagnostic testing belongs in that workup first. Harden and colleagues, publishing in Pain in 2010, validated these criteria against the older standard. Specificity rose from 0.41 to 0.68 in the clinical version, which held sensitivity at 0.99. The research version reached 0.79 and bought that number by letting sensitivity fall to 0.78 more missed cases. The clinical version belongs at the bedside. The research version belongs in trial enrollment. You lie prone. Temperature probes go on both feet and record a baseline before anything is injected. The C-arm angles obliquely until the vertebral body's anterolateral corner is in profile. The needle advances to that corner at L2, L3, or L4, with depth confirmed on a lateral view, just anterior to the vertebral body in front of psoas, then contrast under live imaging. Correct spread is a smooth longitudinal column hugging the anterior vertebral margin. Feathering into psoas means too shallow. Instant washout means a vessel. Tracking toward the neuroforamen means too posterior. Only a correct pattern earns the local anesthetic. Now the anatomy pays off. A technically successful block raises the skin temperature of that foot because vasomotor tone has been released, while strength and light touch remain intact. No numbness, no weakness. That is also how contamination is caught. If light touch or strength changes afterward, anesthetic has reached the nerve root or the somatic plexus. The test is no longer clean, and whatever relief follows cannot be credited to the sympathetic chain. Sensory and motor testing afterward is what makes the result readable. A temperature rise proves the block worked technically. It does not prove your pain is sympathetically maintained. Relief afterward is suggestive, not conclusive. A single unblinded block carries a high false positive rate from placebo response, systemic absorption, and somatic spread, and the outcome evidence deserves your skepticism. In 2016, O'Connell and colleagues assembled for Cochrane every randomized trial on local anesthetic sympathetic blockade in this syndrome. The yield was 12 studies, 461 participants, everyone at high or unclear risk of bias, the evidence graded low to very low quality. Their conclusion: the limited data do not suggest this block is effective for reducing pain in this syndrome. A 2018 review in the Canadian Journal of Anesthesia by Duong and colleagues is sometimes quoted as a rebuttal. It is not one. Its 35 trials span the whole field of treatments for this syndrome. Sympathetic blockade gets a single unpooled sentence with trial quality called variable. That does not overturn Cochrane. Reported adverse events were minor, but risks are real. Bleeding, infection, intravascular or intrathecal injection, puncture of the kidney or ureter, somatic nerve injury, genitofemoral neuralgia, post-sympathectomy neuralgia, transient drops in blood pressure. Relief from a single block is often short, hours to days. The honest position is this: it is a diagnostic trial that can buy a therapeutic window, not an open subscription, and the value lies in what gets done inside that window. Desensitization, graded motor imagery, loading the limb, moving it. Diet, specialized pro-resolving mediators, photobiomodulation. For this condition, adjunctive and emerging, nothing more. I use them to lower general inflammatory load, not because a trial in this syndrome supports them. There is none that does. I will not price them as treatment for this condition. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. An ankle fracture, immobilized, healed radiographically. Weeks after the cast came off, burning pain out of proportion, a foot swinging between cold and flushed, sweating on one side only, touch sensitivity that made socks impossible. 2 clinicians had already called it nerve pain from the back. The Budapest criteria had never been applied. Applied, they were met without argument. Symptoms in all 4 categories, signs I could observe in 3 of them. The first block was ordered to answer a question, not to treat. Foot temperature climbed 4 degrees Celsius while strength and light touch stayed intact. Technically successful. Pain fell substantially for roughly 2 days, then came back. The patient heard that as failure. I read it as 2 pieces of information, neither of them a verdict. The response was consistent with a sympathetically maintained component, suggestive and not proof, and we now knew how long a single block buys. The hard part ran for months. Desensitization asks you to do the exact thing the limb has spent half a year refusing: be touched every day. There were plateau weeks and real discouragement when a repeat block returned less than the first. Tolerating a shoe came back long before tolerating cold did, and the cold sensitivity never fully resolved. That is a real course, not a highlight reel. If your limb burns, swells, or changes color after an injury, you deserve a physician who applies the criteria before the needle and tells you plainly what the evidence does and does not support. Padda, Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902. Monday through Friday, 8 in the morning to 5 in the afternoon. Read the full procedure page at painmd.tv, examine the limb, close the differential, then decide. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.